Hi, welcome to You and Your Health. I'm your host, Dr. David Bertone. Today we're going to talk about recent advances in spine surgery. Over the 25 years of practice as a physical therapist, there are times in which patients do require spine surgery to fix their low back pain. We're going to hear today about some of the recent advances and things that you should be aware of before you go and have spine surgery. Our guest today is Dr. Gordon Donald. Dr. Donald is a board-certified orthopedic surgeon and board-certified spine surgeon. He practices here in Eatontown with the New Jersey Spine Group. Dr. Donald, welcome to the show.
Thank you, Dave.
Tell me a little bit about your background.
Well, you know, my background is interesting that in college I wasn't really directed towards medicine, but rather towards engineering, and I was a biomechanical engineer in college. And as part of my biomechanical engineering training, I ended up spending the majority of my time in the orthopedic research laboratory and in surgery. Oh. And I decided at that point, you know, this orthopedic surgery is the direction, the future I wanted to pursue. So I became an orthopedic surgeon, medical school in Vermont, trained down here in New Jersey, and subsequently have done a fellowship both in sports medicine and then in adult spinal surgery.
Great.
And I've been in practice as an orthopedic surgeon for the last 22 years. And specializing purely in spinal surgery for the last 15 years.
Great. Now, obviously, you see a lot of patients with back pain. What are some of the common causes of back pain? And when they come to you, what are some of the evaluative steps and things that you would typically do for somebody that has back pain?
Sure. You know, back pain is a huge topic with many, many potentially different causes. I mean, the reality is everybody experiences some degree of back pain throughout their lifetime. Some of it quite debilitating, some of it more of a nuisance and fleeting in character. And it's our job when the patient comes to us to try and figure out what's the cause of their pain. Well, as surgeons, we tend to focus most on the skeletal part of the spine, meaning the bones, the cartilage or the discs that are between the bones, and the nerves, because this is the area that we can affect, that we operate on. But the reality is, and I know this isn't lost on you, this spine model, and this is a model of a low back, is surrounded by muscles and ligaments. And if this was all that we had, this would be something that was just kind of floppy around and have very little functional support to it. Mm-hmm. The reality is it's the muscles, it's the ligaments that give this spine, that give our low back or our neck control and function. And the vast majority of injuries that we see or causes of pain that we see that may or may not be related to an injury are really more affected by the muscles, the ligaments, and the small joints than they are by the bone, the discs, and the nerves. Mm-hmm. So our first step is to try and figure out where is this pain coming from. Is this a soft tissue pain? Is this a muscular type pain? And there are a number of things that we do, spending time with the patient, getting a good history, understanding what causes their pain, what type of symptoms do they have. Do they have just low back pain? Do they have pain radiating down their leg? Does it start in their hip and go to their groin? The history is so important in trying to figure this out. And then the other thing, obviously, is physical exam. Mm-hmm. Actually touching the patient and examining the patient to understand what you're affecting in different structures. Can I cause the pain? Can I alleviate the pain? And that helps give us some idea. And then the last component of trying to figure it out is imaging. Mm-hmm. Whether that be plain x-rays of the spine, more advanced imaging like MRIs, where we can actually see the nerve roots, the discs, and things like that.
Now, typically, you're not getting the patient when they will just have an episode of back pain. So that's where I'm going to see the patient as a physical therapist or their primary care physician. You're typically going to get those people that are having lingering symptoms that aren't responding to conservative care, or severe symptoms that are disabling their function. Let's talk a little bit about what the typical patient will look like when they eventually get to you.
Right. So unfortunately, not unfortunately, but the reality is that I do become the first provider for some of these patients that have had debilitating care. And you're absolutely right. Those are patients that need to be working with a therapist, working in different modalities, pain management, sometimes even chiropractic is very useful for these things. And when do I really want to see the patient? I want to see the patient when they've failed these more conservative type of treatment programs, because obviously if you can be made better without an operation, that's the best of all worlds. Mm-hmm. When we do see the potential surgical patient, they appear in a number of more common type problems. The most common type problem that we see is really something that we call degenerative disc disease. And degenerative disc disease is a bad term because it indicates that it's age-related. And although that's true to some extent, it's probably more genetically related than just from getting old. And it means that these discs, these cartilage structures that sit between the bones that are supposed to act as effective shock absorbers, don't act as such good shock absorbers anymore. And that puts a lot of stresses on the rest of the spine. Fortunately, most of those cases are, again, diagnosed appropriately and treated conservatively. The majority of those cases do not need an operation. But occasionally it gets to that point. The more common surgical procedures that we do are for people who have disc herniations. And disc herniation, just the term disc herniation, which many, many people have heard of and use sort of colloquially for back pain, is really a very specific term. And what it means is that, the disc itself, where it's a sort of a sandwich, a round or oval sandwich around the vertebra, has pushed out beyond its normal border where the tip of my pen is, and now is pushing back on the nerve root on this yellow structure here. And that type of pathology that compresses the nerve gives you pain along this nerve root, and people experience that, some as pain in their back, but mostly as pain in their buttock or down their leg. And that's the more common thing that we see. Fortunately, many people with disc herniation, 70% of people, get better conservative treatment. Over time, good strengthening exercises, use of anti-inflammatory medicines, but some people, the structural compression is just so great that it doesn't get better.
Can you clarify, some people have heard the term slip disc versus herniation.
Sure.
So the public can understand that the disc isn't really sliding, it's really just like a little hernia there that develops.
That's exactly right. Slip disc is commonly used, and it means it should mean the same thing as disc herniation. But these terms get confusing because people use them, throw them around so casually that they kind of lose their meaning. But a slip disc or a herniated disc is really describing the same pathology where the material has come out and is now pushing back on this nerve root.
Let's go into some of the surgical options, some of the simple surgical options for something like that, a disc herniation.
Sure.
And some of the advances and techniques that are used for that particular problem, because I think it's important for the public, because that's very common and you see quite a bit of those.
Absolutely.
What is involved when conservative care failed and now it's time to do something about it?
So when we get to the point where you continue to have symptoms from this disc herniation pressing on the nerves and conservative treatment has failed, we need to remove that compression that object pushing on the nerve root. In the past, the way that we used to do that, if we have a model, so now the patient is lying face down based on this model, skin is up here, remember that his back are all muscles that envelope the spine. And in the past, we used to make relatively large incisions, strip the muscles off of the spine, and come down to open up the spinal canal, come down where the tip of my pen is, where this disc herniation is, and we'd literally remove all of the disc material around there. And the reality is that did a great job getting the pressure off the nerve root, but it was so insulting to the muscles and the structural support of the spine that people had a lot of lingering problems after that. And you know, many times people say, gee, if you ever have your back operated on, you're never the same again. And that's because we did so much damage getting to the pathology that we fixed that it was true. It was never the same again. But now, those techniques have changed dramatically. Now we do minimally invasive procedures for disc herniations where we're using a microscope, we're making very small incisions and barely moving the muscle off the spine so that we can come down and remove just that material, like in the tip of my pen, that's pushing on the nerve root. Those patients are now done as outpatient procedures. You go home an hour and a half after your surgery, and you're ambulatory, you're walking, you're doing things. And typically, I start those patients back into an exercise program 10 to 14 days after their surgery, back to full activities in about 6 weeks.
I think the key is that there's a proper indication and you see the exact problem and you go and you fix that exact problem. I think the perception of people is that when they have back surgery that it's, you know, very complex and there's lots of things going on for something simple like that. Right. Obviously there's much more complex procedures that we're going to get into. But a simple disc herniation, and this procedure is called a microdiscectomy, right? Is much easier on the body, and they recover much faster.
That's correct. And your initial point that you have to understand exactly what the offending pathology is and direct your treatment to fixing that couldn't be more true. Whether it's a relatively simple pathology like a disc herniation or it's a more complex pathology like spinal deformity and stenosis. Mm-hmm. We have to know exactly what we're fixing. As surgeons, we rebuild, modify, correct structural anatomy. That's all that we do. Mm-hmm. We don't make the muscles work better, frankly. On the far side, where our potential is to make the muscles work more poorly than they already do. We want to avoid that. Mm-hmm. We fix the structure, and then it's part of the post-surgical treatment is making those muscles work better, getting the patient functionally stable and back into activities.
Great. You know, obviously this disc herniation is a big issue, and you see a lot of them. When we come back after the break, we're going to talk about some of the more complex conditions that require more advanced surgeries and some of the recent advances in things like disc replacement that we're hearing about now that are going to bode really well for the future.
Very good.
Okay, so you've been watching You and Your Health, and we'll be back with Dr. Donald after the break.
I remember the moment.
I'll never forget that moment.
That changed my life.
At that moment, it hit me. This is why I joined the Guard. We're soldiers, always ready to protect our country. But we've also got communities. Family, friends, neighbors who count on us. I couldn't believe it. I just saved a life. Somebody from my hometown.
See what it means to be a citizen soldier at NationalGuard.com.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Today we're speaking with Dr. Gordon Donald about the recent advances in spine surgery. Thanks again, Dr. Donald, for joining us.
Absolutely.
So we talked about disc herniations in the first half of the show. Can we talk about some of the more common other procedures that you do for back pain, things like stenosis, and what some of the surgical options are for that?
Sure. So spinal stenosis is certainly one of the most common things that we see patients for that have lingering, debilitating symptoms. And spinal stenosis, unlike a disc herniation, that people can usually tell you when it started, the day, the week, sometimes the minute that it started. Spinal stenosis is something that occurs over time, and people become more and more debilitated by it. Rather accepting, they're able to compensate, they're able to accommodate to it to a point. And then by the time they come to my office, they're just miserable. And their function is dramatically affected. And what it is a narrowing of the spinal canal. Let me use my pen here. If we looked at the spine in a cross-section, and this is the spinal canal, the area where the nerve roots travel through, the yellow is this sac of nerve roots. Spinal stenosis is simply a squeezing of the sac of nerve roots due to a variety of things that occur in the spinal canal, but they occur slowly over time. And people will tend to have very postural type symptoms, meaning that their symptoms change between standing and walking, sitting down, lying down. And the reason for that is if we looked at our MRI, if we looked at an image of spinal stenosis, it would almost look like an hourglass. So you have a nice spinal canal, it gets very narrow, and then it opens up again. Well, an hourglass obviously is fixed, it's rigid, it doesn't change. But our spine changes, and as it flexes, and as it extends, as the spine moves, as we assume different postures, that spinal canal gets larger, and it gets smaller.
So positional changes can affect it.
So positional changes affect it dramatically, and I know that that's one of the things that when you work with a spinal stenosis patient, you spend a lot of time doing those things. And that's important to note because it affects how we treat, today it affects how we treat the patient, even surgically.
Okay.
So in the past, well, we said you had a narrow spinal canal, the nerves are squeezed, and oftentimes the nerves are, that stenosis, that squeezing of the nerves develops because the segment of the spine actually is weak. It allows extra movement.
So it's unstable?
It's instability, that's right.
Okay.
And the thickening of the ligaments that cause the stenosis is really a reaction to that instability. It's our body's reaction to try and build structural support.
So you need to open that space up? Is that
so
what's
in the
involved?
past, we would open that space up. Part of opening that space up, of course, would be removing those ligaments that had thickened, that had gotten stronger to add stability. That means that we're creating more instability. We're removing that structural support. So in addition to opening up the space, we would have to rebuild the structural support of the spine. And we would do that by fusion, by making that segment solid, adding screws into the bone, connecting these screws with a rod, sometimes putting cages, these sort of I-beam type devices in between the bones, all to add structural support. And that works very well. That's traditionally what we've done for the last 10 years. And that works well in getting rid of the symptoms of the nerve compression, works well in restoring structural support to the spine. The problem with that is that it makes the spine rigid. A spine that normally moves, it makes it immediately rigid over that segment. And it increases the stresses on the spine, either above or below that stiff segment. And although we don't see problems with that in the short term, over the long term, many people develop problems just due to that change in mechanics of their spine. So we've changed some of our techniques, and many patients that have this problem are now more amenable to a much simpler surgical treatment, a minimally invasive treatment, where, like our disc herniations, we can start the procedure with a microscope and just open up the spinal canal around the nerve roots. But instead of rebuilding the structural support with 4 screws and cage and bone graft, a rather formidable procedure, we're now using a small device that fits in between the bones in the back of the spine, and it just provides enough structural support, enough stability, that the patients do exceptionally well long-term, just as well as our fusion patients do, yet they still maintain some motion so they don't have the dramatic mechanical changes above or below. And in the long term, we're seeing better results with a lesser surgical procedure than we did with these larger surgical procedures.
So this is a natural progression. I would assume that when you did, when you cleaned out the space many years ago, they didn't really start putting any cages or anything in there. They just saw that it became unstable.
That's exactly right.
And then eventually said we need to use some support in there, and they did that. And now you're learning that it creates problems above and below.
Right.
And
so
now the next step is, let's get rid of that.
Yeah. So it's like many problems that we face, whether it's in surgery or everyday life, where, gee, we do something, oh, we've got a problem, and well, to fix that problem, we end up over here, and that fixes that problem. Yep. But the real answer is somewhere in the middle. And we've come back to that middle now with these more minimally invasive procedures.
I think that's where people get concerned when they hear they need to go for back surgery, and people say, well, you're always going to have back pain. Is that they're thinking about some of the older techniques that are still used.
That's exactly right.
And that there's newer things out there that can really dramatically reduce that chronic nature of the back pain if done correctly.
Right. That's very true. And we're also paying more attention to the natural history, as you said. You know, people who have arthritis in one hip, maybe they have a joint replacement, and that feels pretty good, but they develop arthritis in the other hip. Well, that didn't have anything to do with the first one. People who have degenerative changes and stenosis at one level may develop it at multiple levels as well. And we want to try and not make that worse. And we found that by dramatically changing the mechanics of the spine, we tended to make that worse. Now we're back to fixing the problem at hand. Again, identifying what that structural pathology is that's causing the patient's symptoms, and trying to not only fix that, but avoid problems at other levels.
Great.
So we're paying more attention.
Now let's move on to the big picture of the disc. And a lot of people have failed disc problems or severe degeneration of the disc, and everybody's asking, well, why can't you just put something in there to fix it?
Right.
And for years, nobody could figure out what to do with it. And tell us about some of the advances with disc replacement surgery.
Sure. So the problem that we're talking about is this concept of degenerative disc disease, where the disc itself, this spacer between the vertebra, this shock absorber, simply doesn't work very well anymore. And that can lead to back pain. It can lead to a variety of problems. And you're right. People come in my office every day and say, gee, doc, can't you just pump that disc back up? Can't you inject something in there that makes that a good shock absorber again? It's a great idea. And frankly, there's a lot of research towards doing things like that. But unfortunately, it doesn't exist in humans today.
Okay.
So our treatments have been, geez, if the disc is the painful structure and it's not doing a good job from a mechanical point of view, we have to remove that disc and rebuild the structural support of the spine. And much like our discussion with spinal stenosis and how that treatment paradigm has come back towards the middle, I'm going to show you that that's true for degenerative disc disease as well. In the past, we used to fuse it, and frankly, we still do much of the time today, depending on the pathology. When we remove this disc, we put in a solid structural support, what we call these cages, which are basically I-beams between the vertebra. And bone graft goes in here, and this all grows together as one solid piece. Again, great treatment, especially in the short term, for treating the source of the pain. But it changes the mechanics of the spine, and we develop problems at other levels. One of the tenets of doing this procedure for degenerative disc disease is that, you know what, you can get away with this in 1 or 2, occasionally 3 levels, but if you're doing it for 3, 4 levels, the results are so poor long term because you're changing the mechanics that you have to think of other concepts. So now what the most effective thing to do, we still want to remove this painful disc structure. We need to rebuild the structural support of the spine, but we don't want to change the mechanics as much. So instead of putting in these static or non-mobile I-beams between the vertebrae, we can put in a device that sits in the disc space, that removes that painful disc, but it still allows that segment, that vertebral segment, to move. By doing so, you don't increase the stresses as much above or below, and we tend to have fewer long-term problems with this compared to the fusions.
So it's not replacing the disc, it's just putting a more functional structure in there besides a fusion to allow some mobility in
Well,
there.
we actually do remove the entire disc.
Yeah, so but you're not replacing it with
With
another
a normal
disc. Yeah, we don't have that capability yet.
That's exactly right.
Yeah,
and, it would be, in the perfect world, we'd be replacing it with a brand new disc, and you're going to put a new tire on the car, and you're good to go. It's not quite that easy.
All right. So is there, talking about the future, is there any research in terms of regrowing disc cartilage like they do at the knee now in terms of procedures in the knee?
There's a ton of research. We're working with stem cells. We're working with growth factors. We're working with harvested cartilage cells, amnion cells, to try and regrow the failed cellular processes in the disc itself. But that's still a long way out. You know, we're probably 8 to 10 years before realizing any of those research technologies on a clinical basis.
And I think that was probably true 10 years ago with something like this, being
That's
able to put something in between the bone, right? You didn't think that was eventually going to happen, and now it's here. It's a reality.
That's right. We started that study in 1992.
Great.
So
So there are advances coming. There are options for patients that are having great difficulty with back pain and loss of function. It's not just fusion at this point. There's other options. In some circumstances, the fusion is really necessary, but then there are some other advances that are possible.
And not only are there more advances, but the whole field is becoming much more minimally invasive. And that's not to say that we're necessarily changing techniques, but we're doing similar techniques much better so that we don't cause as much collateral damage as we used to have in the past. And this concept of my back is never going to be the same again, we want to try and avoid that.
Great. Well, Dr. Donald, thank you for joining us.
Thank you, David.
We really appreciate it. You've been listening to You and Your Health. I'm your host, Dr. David Bertone, and we'd like to thank Dr. Gordon Donald, a spine surgeon, for coming in and speaking with us about the recent advances in spine surgery.